Good morning, everyone. Welcome to this webinar for the SBRI Healthcare Competition 17 launch. Competition topic is urgent and emergency care, and the call opens today. So what I'd like to do is, well, first of all, welcome you for coming. Thank you for coming and giving us your time. And I'd like to particularly welcome three guest speakers this morning. Dr. Chris Turner, who's an urgent a consultant at University Hospitals Coventry in emergency care, Professor Paul Dimitri, who has a very long string of job titles, but in particular he's a Professor of Child Health and consultant in Paediatric Endocrinology from Sheffield Children's Hospital, and they're going to speak to the clinical aspects of the theme. And Tammy Holmes, who is from the West Midlands AHSN and head of the Innovation Exchange there, who's going to talk about the AHSN offer a little bit later. And in between that, we're going to have two people from the Programme Management Office, which I should have introduced myself as Ian Newington. I'm also part of the Programme Management Office, and I'll be chairing the session today. There will be two Q&A sessions. So after our two clinicians have spoken, we're going to have 10 minutes of Q&A related to that. For Q&A, can you please use the Q&A box that you've got at the bottom rather than the chat, and we will that will allow us to capture the questions, and after the webinar, which we are recording, we will be able to post frequently asked questions or a set of questions with our answers on the website following this webinar. There's a second Q&A session at the end of all the speaking, which for about 30 minutes to answer other questions. If you have very specific questions, or you have very specific concerns or things that are confidential you don't want to disclose, but you'd like to have a chat with someone from the PMO, at 11:45 we are going to have some one-to-one sessions. You will during the webinar, there'll be an email sent to you, and towards the end we'll post the link in the chat, and you will be able to sign up for a one-to-one session with someone from the PMO from 11:45 if you would like to do that. So if you've got particular questions very specific to your particular idea or concept, and you want to talk about eligibility or any of those kind of things on a confidential basis with someone from the Programme Management Office, please take advantage of that opportunity. So I think that's all I need to say at this point. I will now introduce our first speaker, and we'll go through the first three sessions before we get to Q&A. So I'm going to introduce Fanny Burrows, who's a Senior Programme Manager in the team, to talk about the SBRI programme. Some of you will know it very well, but there may be others of you who haven't been involved with the programme, and so Fanny will run through some overheads of what the programme is about.
Hi, good morning, everyone. Thank you, Ian, for the introductions. So my name is Fanny Burrows. I'm a Senior Programme Manager, and I just want to give you further information this morning about the SBRI Healthcare programs. Next slide, please. So the programme aims to facilitate the introduction of innovative technologies to the NHS. The programme is powered by NHS England and NHS Improvement. It's managed by LGC and is strongly supported by the Academic Health Science Network. The key objective of the programme is really to improve patient outcome and patient care, but also making sure that we can increase efficiency to the NHS and enable the NHS to access innovations, and ultimately being able to bring economic value to the UK. Next, please. So the key features of the programme really is to understand that the programme has got themed competition in order to address specific identified unmet NHS challenges. It's open to any size organisation, so it can be private, public, third sector, any size businesses, and based anywhere in Europe. Particularly, really, the organisations have got to demonstrate a route to market, and the programme is particularly well suited for SMEs. So the programme has got two phases. We've got phase one projects that are awarded for 6 months and up to £100,000. And then following on to phase one, applicants can then apply to phase two projects that are awarded for 12 months and up to £1 million. Next, please. So now what I would like to do is to give you a little bit of an overview of the process and how the applications are assessed. So next, please, Alice. Thank you. Before the competition opens, there's work happening to identify the problem and being able to articulate the clinical need that the competition is to address. And for this, there's a lot of discussion that happens between the Program Management Office, key opinion leader, seeking help from stakeholders, the AHSN, but also really looking at the NHS long-term plan in order to identify those unmet challenges that the competition would like to address. Once the problem is identified and well articulated, then the competition can open. So the application process starts online, and they will give you a bit more information a bit later about that application process. And then so the competition opens today, and then we'll close a bit later in August. Once the competition is closed, the applications are reviewed by a pool of clinical, technical, and commercial experts, as well as the Program Management Office, with a view to shortlist a number of applications to recommend them towards the panel meeting. So typically up to 25 applications are shortlisted at this stage. The shortlisted applicants are then invited to submit a 3-minute video pitch, and those videos will be reviewed by the panel, a panel made of clinical, commercial, technical experts, as well as a patient and public representative. The panel meeting and the panel members will recommend those promising proposals for funding. And then a phase of due diligence will occur between the Program Management Office and the project teams, with a view to then issue a contract between the NHS and the teams. So then the phase 1 project can start, and all the phase 1 project will start at the same time in order to finish a certain point. And at the end of the phase 1 projects, those successful projects will then be invited to apply for phase 2. So again, online on our research management system, a more detailed application form that also include a patient and public involvement strategy. And those applications will then be reviewed by peers, so experts in the field. Before then, they can be reviewed during the panel. So the panel meeting will involve similar panel experts, clinical, technical, commercial, and PPI representative. And the applicants will be invited to present for 15 minutes, and this will be followed by a Q&A session with the panel members. So again, the panel will make recommendations for funding, and there will be a phase of due diligence, then issuing a contract, and then this phase 2 project can start for a period of 12 months. And then ultimately at the end of the projects, the goal is to be able to, for those innovative technology to reach the patients, but also access the NHS, and then to turn into successful sold product on the NHS and have an opportunity for exports. So next slide, please. So just a few things that I just would like to emphasize about the program. First of all, what do we fund? So we fund a number of different costs, particularly well suited for SMEs. All costs include VAT. So we do cover labor, material, capital equipment, subcontractor, but also we do cover indirect cost. One particular point to focus on is that the competition is an invitation to tender. It's a competitive process. And the cost and application are assessed on a fair market value. So we do not fund full economic costs, we just fund a competitive process and fair market value. So that's the main thing to take here. In terms of contract, the program follows EU pre-commercial procurement rules. And the IP rests with the supplier, and certain usage rights remain within the public sector. The payments are made quarterly upfront, and those payments are really milestones driven. And then moving on to the PMO performing monitoring activities as well. It's a light touch, sort of risk-based approach to monitoring. And typically the team meets quarterly in order to review the progress. Next, please. So in terms of success rate for the competition, we've just gathered numbers over a period of time. Just back to the previous one, please. We've got, it's a very competitive process, and around 10% of applicants are successful from the application process to then being awarded a phase 1 project. And then depending on funding, around 50% are funded for phase 2 projects after the phase 1. So next, please. So what I wanted to do now is move on to the competition that we're launching today. And so today we're launching competition 17, and the challenge that we would like to address with this competition is around urgent and emergency care. Next, please. So really what we're trying to focus with this particular challenge is, first of all, to reduce demand, focusing on recognizing the differences between adults and children in emergency care, but also recognizing that respiratory conditions do account for a large proportion and a growing proportion of attendance at emergency department. And the second focus really of this challenge is to reduce the length of stay in the emergency department, for example, by way of more efficient triage, streaming and treatment, but also looking at more efficient admission to hospitals and discharge from the hospitals. You'll hear more about this challenge and the clinical need, but you can find more information on our website, SBRI Healthcare, where you can actually download the challenge brief and have more information on that. So next, please. So now regarding the dates, we're launching the competition today. You can access the portal to see the application process and the application form, and the deadline for submitting application is 27th of August. After that, so that's a compulsory deadline. The assessment will take place in September and October, with a shortlisting meeting at the end of September in order to shortlist a number of applications to be invited to the panel meeting. And the panel meeting will take place on the 21st of October, with a view to start projects and contract being awarded by the beginning of December. Next, please. So now I would like to give you a little bit more information about the program and its impact. And it's really important for us to be able to see how the programs, impacts commercially, but also the NHS. So next, please. There's a number of metrics here from the 2018-2019 financial year that are due to be updated, but just overall. The programme has invested around £90 million to support over 180 companies to bring innovative solutions. And 80 products are actually available on the market to buy, and 23 companies are actually exporting those products. Out of this sort of investment, the programme has managed to leverage further investment in excess of £300 million in private investment to support those technologies. And one key thing really is how the patients and patient care is at the heart of the programme, and how the programme has been able to make sure that patients can benefit from these products. And over 4 million patients have benefited through either clinical trials or sales. So the next one, please. Now is just to be able to demonstrate to you the breadth of innovation that the SBRI Healthcare portfolio has supported. Medical devices, for example, Open Bionics has developed a 3D printed prosthetic arm. Or even diagnostic with Alston Medical. It's a diagnostic tool, sort of breath biopsy, to detect lung cancers and to detect traces chemicals in breath. Digital health, for example, that has been supported through the program, My Health, that is a self-management program for patients suffering with chronic obstructive pulmonary disease and being able to gain greater control over their disease, or services like Citizens that is used by the GP to identify patient at risks and identify risks of cancer. So the next one, please. And as so I've mentioned earlier the AHSN strongly supporting the SBRI Healthcare Programme, and you'll hear a lot more about this later this morning. But the AHSN is really supporting the programme in identifying and articulating the clinical need for the competition. They work across distinct geographies and really connect the NHS with academic organisation, industry, third sector, even local authorities. And they're really there to spread innovation, the adoption, and making sure that patients are benefiting at the end. So you'll hear a lot more about that, and you can also ask questions. So next one, and I think that's it for me this morning. Thank you very much for listening. I would welcome you to look on our website to find out a lot more about the challenge brief, but also invitation to tender, applicant guidance and portal guidance. And you can also apply there. So, and then feel free to get in touch with one of us at the Programme Management Office. Thank you very much.
Let me briefly, thank you, Fanny. Let me briefly introduce Chris Turner, who has taken time out of a very busy job as a consultant in emergency medicine at and at University Hospitals of Coventry and Warwickshire. And well, you can see on the screen a little bit about his CV. So Chris is going to talk to us about some of the things that go on in the emergency department and why this challenge is particularly important. Over to you, Chris.
Chris, you are muted. You have to unmute yourself. Thanks.
Okay, apologies. I'm talking on the phone, so now I can't hear you guys. Can you hear me now? Can you hear me?
Yes, we can.
Yes,
Chris.
we can. Thank you.
Okay, cool. All right, I'll start again. So, good morning. My name is Chris Turner. I'm an emergency medicine consultant in Coventry, University Hospitals, Coventry and Warwickshire. We're one of those big hospitals that you may never have heard of, but we're a major trauma centre. We have up to 700 patients coming through the doors per day. And I'd like to give you a little overview of some of the challenges that we face in the emergency department. I guess one of the first ones is, next slide please. One of the first ones is that we are an enviable and trusted brand. People come to us because they expect a certain amount of service, and the other thing is we are, of course, pretty much a monopoly when it comes to requiring emergency care if you are severely unwell. Next slide, please. And it's just not easy to stop people coming to an enviable and trusted brand, particularly when they don't have another option. So, next slide, please. There are a couple of options in terms of thinking about how we might stop people getting to the emergency department in the first place. The first one is, can we do anything? Can we go back a slide, please? The first one is, can we go back a slide, please? Thank you. The first one is that, are there ways that we can help support decision making for the ambulance crews who get called out to patients? There are already some things which are in place, but perhaps there are ways that we could improve that. And the second part, next slide, is, can we get the next slide, please? The second part is whether or not we can actually stop people from coming to the front door. Now, 15 years of trying to stop people coming through the front door has shown us one thing, and that is, unless there is a major football match going on or a global pandemic, people simply keep coming. And year on year, the number of people attending emergency departments has been increasing despite huge amounts of effort. And quite what that represents is difficult to disentangle, but whatever else it is, it's not particularly low-hanging fruit. Next slide, please. However, once people get to the emergency department, then we get some more opportunities to think about how we might improve efficiency, safety, and how we might make the patient journey better for them. Next slide, please. On arrival at the emergency department, people are screened, triaged according to need. There is probably an opportunity within that area to be considering how we might make the screening happen more effectively. There is a degree of consistency to it, but that could definitely be improved upon. And there are areas where we might be able to help the people who are doing that screening to speed that up and send patients to the appropriate areas quicker. And those same issues probably relate to the doctors who then process patients once they formally get into the emergency department. So next slide, please. One of those is how quickly we can get testing done. Testing is key to decision making. It's second to taking a good history in terms of deciding where a patient is going to go. You might imagine that the test is the definitive thing, but most of the evidence says that the absolute core thing is taking a good history with the right information within that. However, that is backed up by testing. And a lot of the time testing has to go to laboratories where it gets turned around and brought back in. And we are particularly good at that at UHCW. Most of our tests come back in about an hour and a half. However, if we could reduce that time, if we could have point of care testing, which allowed the key tests to come back quicker, then potentially that would help us to turn patients around more quickly. Next slide, please. Allied to the issue of testing are the interpretation of tests. So it's not just the test, it's about how well we can interpret the tests that we do. And X-rays are a good example of somewhere where we're beginning to use machine learning and AI in an attempt to get to more accurate diagnoses quicker. There are other things which have happened in the last few weeks which have provided more opportunity, and one of them just occurred to me a few minutes ago. And that is that at the moment, probably the biggest problem for us in the emergency department in terms of turning rooms around is how quickly we can clean them effectively enough to be reasonably sure that we've got rid of all traces of COVID. And what that means for us at the moment is that we have rooms which are out of commission sometimes for up to an hour or so as the appropriate team comes, assembles, cleans the room, does the things that they need to do, and then leaves the room again. Now, it's hard to see us leaving behind the ideas of how well and how quickly we can clean rooms. And it's not an area that I'm aware of an awful lot of work being done on, but it does seem to be an area that's becoming more and more important to us within the emergency department. And all of these things have potential to speed up the rate at which we can see patients and also the safety for those patients, so the quality of care that we can give. Next slide, please. One thing I want to spend the last couple of minutes talking about is, from my perspective, and the perspective of many emergency medicine doctors and nurses, is, next slide please, the biggest pitfall. And that's this guy. And this is somebody who is sitting in their office and they are thinking about what it is that I do and what my colleagues do. And they form what's called work as imagined. And next slide, please. And to them, this looks like this. It's obviously got quite a lot of stuff going on. There's a fair amount of order to it. But you can make it understandable to yourself by looking at it this way. The reality for me, unfortunately, is, next slide please, the reality for me is it looks more like this. But if you could imagine this picture with it moving around constantly and the wires rewiring themselves. So from my perspective, one of the most useful things that anybody who wants to do work with emergency departments in an attempt to improve safety, efficiency, one of the most useful things that people can do is to come to meet us and to embed with us for at least a little while to get some understanding of the work as done versus the work as imagined when you're on the outside looking in. And next slide, please. And what this sums up as for me is that there are significant opportunities to improve things within the emergency department. However, if we're going to work well with commercial partners in order to try to do that, what we really need is we need people to be able to understand what the reality of work in the emergency department is. And hopefully the academic health science networks are in a position where they would be able to help people to
Sorry, Chris, we've lost your sound.
Apologies. Have you got me back now?
Yes, yes.
Right. So basically, I was just summing up by saying that the academic health science networks are able to put people in contact with emergency departments, with people who are interested in this and supporting this kind of work. And I would strongly suggest that that be a really good starting place for people who have an idea and things that they might want to implement. So thank you very much.
Thank you very much, Chris. Chris is going to be around after Paul has spoken, and we'll have for 10 minutes Q&A to follow up. So if you've got any questions, please use the Q&A session if you want to ask any questions. So let me introduce Paul Dimitri, who is Professor of or the Children CRN Clinical Research Network's National Children's Specialty Lead, and who works at the Sheffield Children's Hospital. Paul, if I hand over to you.
Thanks very much, Ian, and hopefully in a few minutes, a few seconds, I should say, you should be able to see me and hear me. Can I just double check that you can hear me?
Yes, you can.
Excellent, thanks very much. And so that's the introductory slide, just a bit of information about me. I'm a Professor of Child Health at Sheffield Children's Hospital, as Ian said, and I'm the National Children's Clinical Research Network Specialty Lead. And also I lead a technology network, NIHR, Children and Young People MedTech Cooperative. So next slide, please. So the purpose of my presentation today is really to speak with you about the differences with this call for children and young people. Clearly this is a call about urgent and emergency services. But the important part of this is the focus on children, which was mentioned by Fanny in the first presentation. I thought I'd start with a quote that came from a research report that was from the Department of Health and the Royal College of Paediatrics and Child Health back in March 2010. This was deemed a fever study. This was to improve the experience of parents and carers who were seeking advice when their child had a fever. And I think this quite nicely sets the scene. So I'll read it for you there, which is just for reassurance, really. This is from a parent, just for reassurance, really. And just to make sure that somebody else's opinion. Because you know what it's like when you've got kids. You feel guilty for taking them to the doctors and guilty for not. So as it was the evening, I thought I'd ring the NHS Direct and see what advice they had. And I think that sets the scene for the type of anxiety and concern that parents have about children when they're unwell, and how they perceive their access or their requirement to access services. So next slide, please. So starting with the scale of the problem, we're seeing an increase in the number of paediatric emergency department attendances and unplanned admissions in England, and it's getting higher and higher. So back in 2006 to 2007, there were over 3 million attendances of children. So that's those under the age of 16 across the UK emergency departments. And that figure then rose to over 4.5 million in 2010 to 2011. And I suspect is even higher still. And we're seeing an increase in the number of patients, that's children and young people, also exceeding the 4-hour wait as well. And I think the figures also exemplify that the access to the emergency departments for parents bringing children and young people is different. So this is data from the 3-year Yorkshire and Humber Cure study that was published some time ago. But the rates of non-urgent attendance from between adults and children is different. So we're seeing non-urgent attendance to emergency departments in the realm of about 23% for adults, but as much as 31% in children. So there is clearly a difference here as to why children and young people are being brought to the emergency department inappropriately. Again, looking at the figures slightly differently, for every 1,000 children and young people, there are 425 emergency emergency department attendances back in 15-16 compared to 345 per 1,000 adults of 25 years and over that were attending in that same year. And what's interesting is that there is quite a disparity amongst the age range in so much as there are a bigger number of 1 to 4 year olds that are attending compared to other age groups. Next slide, please. So here is a graph that was taken from a document from the King's Fund in 2010 about avoiding hospital admissions. This was from one primary care trust, and you can see there the disparity between the different age groups. So you have a greater number of attendances at the under 4 year olds compared to different age groups, until you see a rise again around teenage years and then young adult, the 20 to 24 year olds. So again, just considering this in terms of the call, a focus around the 0 to 4 age group in terms of trying to reduce the number of attendances in that particular age group. Next slide, please. The knock-on effect of those attending the emergency department at under 16 years is on the short stay admissions following the initial emergency department admissions. So this is the most common the most common stay following an emergency department admission for children and young people, of the short stays less than 1 day. So there's clearly an impact on ongoing paediatric services as well. It's not just about those that turn up at the front door, but actually those children that are kept in for a day or less. So a consideration is required about what happens to those children that are visiting the emergency department that then have ongoing care with paediatric services. And as I mentioned in the first slide, waiting times are now being extended for children and young people receiving urgent and emergency care. What's slightly different, I suspect, between adults' access to emergency care and those in the paediatric age range is that actually very sick children tend to be brought directly to the emergency department by parents rather than by ambulances, and that's often without warning. So there is a different perspective on how children are brought to the emergency department, and obviously how those working within paediatric services within the ED are required to respond. Thinking about the needs then, there's a pressing need to understand the factors that determine the utilisation of urgent and emergency care services for children and young people, and to identify factors which slow the flow of children and young people moving through these services. What we also need to think about is services and technologies that will support the care of children to refine and limit their utilisation of these services, and to consider the development of technology that improves their assessment. Part of that is about refining triage as well, to ensure that services are accessed appropriately, and there is the ability to determine those that need to be seen urgently, those that need to be seen less urgently, and importantly, those that could potentially be discharged from the point of triage. And that also resonates with this issue of trying to identify patients that are safe to be discharged earlier. And clearly there is a high level of anxiety for those looking after children and young people about discharging patients early, with the risk of them either returning more unwell, or worse still, that results in the death of a child because of inappropriate discharge. So that and part of that is also about ensuring that the discharge of children and young people from UX services is supported by appropriate education for parents and appropriate education for children and young people. Next slide, please. So I've mentioned earlier about the differences in children and young people, and there are a number of considerations related to this call when you're planning the development of technologies and looking at data relating to children and young people accessing urgent and emergency care services. I think firstly, and it's a statement that's been around for many years now, is that children are not mini adults, that they do present with different problems, that clearly the trauma side of things may be quite similar, but some of the more medical based problems associated with those that turn up to paediatric emergency services are very different. And the other consideration within that is this versatility in care, that we see a broad age range right the way from those that are within the neonatal period up to those that are at the middle to latter end of the teenage years. So there is a change in the physiology, the anatomy and the development as we go through those ages. The dynamics are different within those presentations as well. So whereas with adult services, you may only be dealing with one person, with those attending paediatric emergency services, we could be dealing with up to 2 or even 3 people, or maybe more, when a parent or parents or families attend with them. There are also safeguarding considerations, both in and out of hospitals. So for those that turn up in the paediatric emergency care department, we have to think about the possibility of safeguarding issues, both indirectly and directly associated with their presentation. Staff need to be appropriately trained, so it's not reasonable to say that all those working in the emergency department across paediatric and adults have the same skills. There are certain skills that are required for those working in paediatric emergency care services. And those services also have to be age appropriate, and not only both in hospital, but out of hospital when planning services that will support or limit the access to paediatric emergency care services by making those age appropriate services outside the hospital. Discharge planning from UX services needs to include advice to families about ongoing care, and also those facilities that may be there to support ongoing care, again, need to be age and family appropriate. There are mental health issues associated with children that are different to adults presenting, and also we look after children with complex needs that are sometimes very different to those attending the adult emergency services, so consideration needs to be given to that as well. And data sets will require additional information, and I'll go on to talk about that briefly in the next slide. Next slide, please. So just thinking about the things that drive parents and young people to attend emergency services, they are different. So parents often explain their choice differently in terms of bringing their child or their teenager to an emergency department. I think this highlights the statement that was made in the first slide, which is partly about their anxiety, that there is an uncertainty about illness within their child, and that heightened level of anxiety drives access. But there is also uncertainty about how what the relevant care is for those accessing GP or primary care services. From a healthcare professional perspective, and I think this is more from a primary care perspective, healthcare professionals are often less confident in diagnosing and treating children and young people. And that's not to be disparaging about my colleagues in primary care who provide an excellent service, but children presenting, particularly those with medical problems that are presenting with illness, their symptoms are often quite non-specific, which makes it quite a lot more difficult to diagnose children and young people, not to mention the fact that many are, in the younger age, are unable to vocalize their problems as well, making it more difficult to diagnose. So we need to consider the dynamics driving access to the emergency and urgent care services for children. And those are around possibly anxiety-related issues, different socioeconomics, geography, whether ethnicity plays a part, and also access to local services. And of course, whether there are other factors which drive families to attend with their children to those services, which may result in an inappropriate admission to the urgent and emergency care departments. Next slide. I would urge you to read this document, there's been several iterations of this document. The previous one, this is from 2018, the previous one in 2011. But this highlights the issues and the standards that face emergency departments, paediatric emergency departments across the country. And in total, there are 70 standards, and they cover a number of different areas, which I'm not going to list off in detail there, but you can see the breadth and depth of information covered in this document. And I would urge you, if you are planning to develop technologies or look at data relating to urgent and emergency services for children to look at this document to help guide you. Next slide, please. And the other thing I would urge you to do is to speak to children and young people. It's enormously important when planning new services, when developing technologies, that you speak to children and young people to get their view. And this is a table from this document, Facing the Future, Standards for Children in Emergency Care Settings, from a group called And Us, which is the Young Persons Advisory Group at the Royal College of Paediatrics and Child Health. And I've highlighted some of the statements from this. So the first is, who is the patient? So talk to children and young people, not just their parents and carers. And think about what they want to know and who needs to know about them, and who do they want to know about their care. And I think this also, resonates around the issues for safeguarding. Reassure young people that you have listened to them and heard and acted upon what they have said. And my experience of working in a number of different fields around paediatric healthcare and paediatric technology development is it's an imperative that you speak to children and young people as you're developing technologies. Also think about involving them in their services. Where did they want to go next? And have a conversation with children and young people about planning their ongoing care, what they would like and what they would feel appropriate. And also speak to them about how they could be treated, how they want to be treated, who should be treating them, and who they would like to be with them when they are being treated. And I think finally, and I think this statement it sums everything up within this, is involve them. Article 12 for the United Nations Convention on Rights of the Child should involve children and young people to have access to the best healthcare possible. Next slide, please. I mentioned in a couple of slides ago about data considerations, and some of you may be planning projects that look at data. And there are additional data requirements to consider around children and young people. So some of those include the name of the person with parental responsibility and the name of the person accompanying the child to the emergency services, because that may not always be the parent. And there may also be issues around social care and guardianship and who has guardianship or parental responsibility of the child. Think about the mode of transport to hospital as well, because sometimes the mode of transport for children and young people is different to a mode of transport that may be used for adults. In terms of the wider support network, those children and young people may be going to a nursery, a school or a college, so information needs to be documented about access to education. And also think about the name of other healthcare professionals in the primary healthcare settings and schools that may be relevant to the care of that young person. And also think that the GP may be different from the child. So don't always assume that the GP is the same for the parent and the child. And that within any data system, there needs to be a good method of clinical coding, because the presentations of children and young people are different to those from adults. So the clinical coding systems do need to be different. And whilst this sounds like an obvious statement to make sure that the coding can be, there is an age identifier within there. And whilst it sounds like a surprising statement to make, I have seen a number of databases where it's been challenging to identify age of the patient. Next slide, please. So this is my last slide, and this is around quality indicators. And this, the quality indicators comes from a document from the Department of Health from 2011. And clearly these will apply to care at all ages, but good care will invariably satisfy 4 criteria: that it must be patient focused with reports of good experience. We must have the best health outcomes with minimal risk. That care must be timely and in the best location, and that relates to the inappropriate use of urgent and emergency care services and whether we can provide better or different care to avoid that, and that we must make sure that the care and the treatment we offer is correct first time. So when you're looking at those, consider the care of children within those 4 quality indicators. But also remember that children in the emergency department represent a distinct group with differing presentations and management to those related to adults. That parents will determine the use of the services for children and young people, and children and young people offer different challenges according to their age and development. Thank you.
Thank you very much, Paul. So there's opportunity to ask Chris and Paul some questions. We have one question already for Chris. So Chris, if you're available, I don't know if you've seen the question, I'll just read it out. It says, thanks for the presentation. How can we ensure that emergency departments have capacity and bandwidth to allow innovators to spend time in the environment, virtually or in person, to develop good fit for their innovation solution? Chris, are you still there?
I am still here. Can you hear me?
Yes, can now.
Excellent. Okay, so the bandwidth question is a really important one because people are so busy. But within many departments, there are people who lead for research, and they have various different interests. And I think that if you are able to get into contact with the department, if you're able to do that through a trusted source, for example, the AHSN, then that might provide the opportunity to create the relationships which allow people to come in, see how the system works in all its chaotic glory. And I do think that that's a really important thing, that people manage to see how it actually functions for the staff who are there. And usually, I think you'll find that people are more than willing to engage with this. It just takes a little while. It takes a little bit of effort, but you can't take the chaos out of the system, because that is what the system looks like. Now, maybe somebody out there today has got the great idea that will take some of the chaos out of the system. I don't know. But in the first place, you're going to see the system in its chaotic glory. But people will find time and they will engage with you. We're cheap. We're a cheap day. We'll sit down with somebody for a cup of coffee.
That's great, Chris. Thank you. So another question for you, actually, straight away. Regards to the key opportunities which could benefit from innovation, you mentioned two key buckets, being prevention and once in ED reduction in length of stay. Would you agree there's an opportunity to better understand the volume and nature of incoming demand? This will likely directly impact the flow in ED.
Absolutely, understanding the incoming demand, but also understanding that it probably varies around the country for different hospitals. We know that when hospitals are located, this is just an example of this, but we know when hospitals are located in inner cities, they are frequently used as a kind of de facto GP. We know that when hospitals are further out of cities, it's less likely that that will be the case. And there are lots of statistics that are bandied around by various people at various times, saying things like a third of emergency department attendees don't need to be there. That's fine, but finding the place that they can go in the time that they need to get there is clearly a challenge to a lot of patients. And we've spent a lot of time and effort trying to understand that. And I suspect there's a lot more nuance to this than the headlines actually give us.
Okay, that's great. Are there any more immediate questions for Paul and Chris? We've got 2 or 3 other questions in the Q&A at the moment, but I think those are slightly more generic, and we'll pick those up after the next in the larger Q&A session. Right. Okay. So I think at the moment we're so yeah. Well, it's a question, and this might be one for either Chris or Paul, actually, just for your comment, and that is someone who's developed a technology for emergency services, but has really struggled to get the product seen and known. There's obviously other issues that are related to that, but I wondered if you had any specific comment, particularly relating to the opportunity to work with people in ED or to see how it really works.
So maybe I can start with that, Ian. So thank you for the question. I mentioned at the beginning, I lead the NIHR Children and Young People MedTech Cooperative, which is one of the 11 NIHR MedTech and in vitro diagnostic cooperatives. Whilst the product may be out of scope from our 7 themes, I also lead what's called the TICH network, Technology Innovation Transforming Child Health, which is a national network to support the development and adoption of technologies for children and young people across the country. And so that gives us a wider scope to look at different technologies. If you visit either our NIHR SIP MedTech website or the TICH website, so if you put TICH technology into Google, you'll get the TICH website. There is a form there that you can fill in that will ask about your technology, the stage you've got your technology, and what you're looking for, and then we can look at that and put you in touch with the relevant colleagues to take that forward.
Chris, did you have any comment on that one? Or
I would just, well, Paul's coming at it from a high level structural perspective, and I'm kind of, as you're probably getting a feeling for, I'm more about the sort of individual interaction that you can get to quickly, and as an alternative way, I think contacting AHSNs and just asking to speak to people. I know that might feel difficult when people have ideas about sort of keeping things to themselves and not letting the cat out of the bag, but most emergency people will happily sit down and have a conversation about whether or not a product or technology looks like it might have utility in our world. And that's the sort of thing that would help to refine it at an earlier stage as well.
thank you.
So again, I'm back to talking.
No, absolutely. Someone would be interested in Chris and Paul's comments on the role that social care innovation could play in reducing demand on ED. There's been a couple of questions around social care and potentially in the role it might play.
I'm happy to chat for a second on that, if that's okay.
Sure.
You okay with that, Paul? So the social care aspect of this is absolutely massive from my perspective, from the perspective of adult emergency medicine. Majority of our particularly sick patients are elderly. Many of them come from social care. If we can find ways which help to support people within social care so that they get the right level of care for them, potentially in the right place for them, which is often not hospital. Hospital is a really bad place to bring a lot of older people, particularly if they have memory problems. We make them sicker by bringing them into hospital. If we are in a position to really truly understand what the right thing for patients well in advance, and I'm thinking about things like the Red Bag Project, which some people may be familiar with, but if we're in a position in advance to think about the appropriate levels of care and how we might provide care within social care settings, then we could probably do an awful lot of patients a big favour.
So just to add to what Chris has said, and I think the demands are different for paediatric emergency healthcare, but there are clearly issues around social care and also around mental health as well. So some of the issues relating to social care and also mental health issues in children and young people do have a significant impact on the emergency services. So I would absolutely agree with Chris that looking at the social care services and social care support has the potential to alleviate the burden on paediatric emergency services as it would with adult care.
So one particular question directly, I guess, for you, Paul, is have you got statistics really regarding children and young people and how long parents wait from concern arising to arriving at ED? Is there any of that information known?
I think the answer to that is no. I don't have statistics to hand, and I think it's an interesting question. That is to at the point of which a parent becomes concerned, how long do they stay at home or visit their GP, or then go directly to access emergency services? And I think there will be a variation both in region and within region and between regions. So and it will also depend on the problem as well. It will also depend on the age of the child, and so there'll be variation across the different age groups. As I mentioned earlier in my presentation, part of the challenge is the ability of the inability of young children to vocalize their problems, which then makes it much more challenging for parents to predict what's going on. I think it's an area that does need to be looked at, and we need to understand that in terms of the access to other services within the region or city, the type of presentation, their access to NHS 111 in terms of how they utilise that, and also the time taken to get them to hospital and how they're brought to hospital, whether they're brought directly by parents or whether they access paramedic services to do that. So I think there's a whole lot of information around that I know colleagues of mine within the Yorkshire and Humber region have been looking at some of that data, but I think we need a more in-depth view of the issues relating to that.
That's great, thank you. And there's a question for Chris. Would having access to all the information that GPs, mental health and social services have about a person at the point that they arrive at ED, you're smiling, I can see, would that be helpful?
Yeah, we are simultaneously data rich and data poor, and instantly I'm thinking about MP Fit. But yes, of course, having access to data is hugely important, particularly the personalised data around the patient. And you know, if anybody could crack that one, I think that would be a fantastic thing for us.
Right. I'm just conscious of the time, and I'm also conscious of the fact that I know Paul has something else to do at 11. So, and we've got some other things we need to do. The other questions that are in the list are generally more about scope, which we will answer in the second Q&A session. So, Paul and Chris, thank you so much for your time and for your contribution. Very much appreciated. Just to a couple of things before we move on. Just to say. Remind you, by now you will have had an email in your inbox and around the one-to-one sessions. Just to let you know, it's a drop-in session. You don't have to register particularly. Just turn up, click on the link. You'll be put in the waiting room for the Zoom if there is a waiting room, and a number of the PMO will be sitting in breakout rooms, and you'll be managed into one of those rooms to talk to us if you wanted to have an individual session to talk. So we'll deal with the most of the other questions, I think, as we reach the Q&A session later. So the next part of the talk of the webinar is to talk about the practicalities of application. Those who are familiar with SBRI are going to find it slightly less familiar this time around if you're going to apply, because we're going to use a different portal. So Aisha, who's part of the PMO, is going to introduce that and talk a little bit about the application process. So over to you, Aisha.
Just give me a second. Thank you very much, Ian. So hi there, my name is Aisha, and as Ian mentioned, I'm also part of the SBRI Healthcare PMO. Now, the following presentation will very briefly take you through the new application process and the assessment. Next slide, please. So to get you started, once you navigate to the SBRI Healthcare website, you'll be able to click on the blue link in the middle there, and this will enable you to access details of the recent challenges and the briefing events. Next slide. This will then take you to the open competitions page, where you can access the documents for competition 17 titled Urgent and Emergency Care. And other hyperlinks also available on this page include the invitation to tender, the portal guidance, the template application forms, and also the frequently asked questions. Now, before we move on to the next slide, some important dates to note, which also have been mentioned throughout the briefing events today, are the deadlines for the application which is the 27th of August, the assessment and panel meetings, which are scheduled for September and October, and finally for the contracts to be awarded in November and December. Next slide, please. Now, the next stage is then the registration and applications login page. Here you can either log in on the left as an existing user or create a new account on the right. Now, in the spirit of keeping the time, when it comes to registering as a new user, the process is fairly straightforward. Primarily, you will click on the register button and you will enter your email, complete the relevant registration details, tick the boxes with the terms and conditions, and then you finally click submit. This will then send a temporary link to the registered user email account. And from this, you'll be able to navigate back to the application portal login page, where you can then log in on the left. Next slide, please. So once you're on the portal, you'll be greeted by this page, which has several tabs. However, the important one to note, especially when it comes to registration, is the Manage My Details tab, which enables you to update your CV and also enter other relevant detail prior to starting a grant application. Now, when it comes to starting the grant application, on the right there, you can select the hyperlink, click here to apply for funding from one of our grant streams. Next slide, please. You're then on the page with the open funding rounds, and you can select the hyperlink apply against the relevant round. In this case, it would be Competition 17, Urgent Emergency Care. Next slide, please. Once you click on this, the first page of the application displays, and here you are greeted by a short introduction and also information on the application form. Now, the primary requirement is that you complete all of the mandatory elements, which is on the left there, that are comprised of the tabs there on the left. And once you have completed all of these sections, you can then click on Save and Close from the top right hand of the application, circled in red. Next slide, please. And yes, and then this will then take you to the take you to the Submit Applications form page, where you have to select the submission, and this will then enable you to submit your application, and then eventually take you back to the portal slide. Next page, please. Now, another thing to note is that before we move on to the assessment criteria today, you may well be nominated or nominate someone as a grant participant. Now, once you submit the form, the individual that you have nominated, or if you are nominated, will be emailed with a specific link to participate on the grant. They are then also, of course, requested to register on the portal, and from this they will be able to select the co-application tab, where they can then follow the instructions for the relevant pre-submissions and confirm their participation. Next slide, please. It's very important to point out that if you have nominated someone or you are nominated as a grant participant, to confirm your acceptance of this. Next slide, please. Now we're reaching the end of this presentation. I'd just like to briefly take you through the assessment criteria that are used to score the applications. Primarily, we'll be looking at the effects the research proposal has on the urgent and emergency care briefing, carefully assessing the project plan, the deliverables, and risk mitigations. We'll also be looking at the competitive edge the technology has, the level of innovation, use of intellectual property, as well as the appropriateness of the commercialization and implementation plans. And finally, we will also assess the expertise of the team and their ability to actually deliver the project. And yeah, and on the last note, whether the costs are justified and also appropriate. So that then brings us to the end of like what the application process is like and the assessment criteria. And I will now pass you on to Ms. Fanny Holmes, who is from the AHSN. Thank you, Ian.
Thanks, Aisha. Just to briefly introduce Tammy Holmes, who from the West Midlands Academic Health Science Network, and who's head of the Innovation Exchange, who's going to give you an overview of the what the AHSNs do and potentially how they can help you in this process. So over to you, Tammy.
Okay, thank you very much for the introductions. As Ian says, I'm Tammy. I'm the head of Innovation Exchange at the West Midlands Academic Health Science Network. So I'm going to give you a bit of a brief introduction to the network, including who we are, what we do, and how we've started it, how we work with the SBRI. Next slide, please. So in the simplest form, the AHSN network is a network of networks, both across the AHSNs, but within our respective regions. The 15 AHSNs were set up by NHS England in 2013, and we were relicensed in April 2018 to operate as the key innovation arm of the NHS. Our purpose is very much to transform lives through innovation, and we have a vision to be a global leader and to be the best adoption network in the world. Next slide, please. So as a UK-wide network, we act as catalysts for innovation, and we do that by helping to facilitate change across the whole health and social care system. We connect regional networks of NHS and academic organisations, but also local authorities, third sector, industry and citizens and patients, ensuring that we're responsive to the diversity of the needs of our respective populations. And in doing that, we can obviously help people get things to the right people in the right places and hopefully at the right time. We will create the right environment for relevant industries and innovators to work more effectively together, but also we collaborate by identifying successful innovations in our local and regional communities, supporting the spread of these across the national network at scale and pace. Next slide, please. So we're very unique in what we do, and our strength very much lies in our ability to operate locally because of the trust of the members and the stakeholders and the organisations that function within it. We understand the needs of our health system, and we're well placed to broker innovative solutions while collaborating across a national level to scale up innovations across the UK. We provide a bridge between the national impact and the local delivery, and what we do is act as a broker between the NHS and industry and other trusted partners to ensure that solutions are signposted to the right places. As organisations, we're embedded in the local systems, and that means that we can work across the different sectors to understand, but also to be responsive to the needs of this system and help innovators navigate that landscape. And by being that connected network at national level, we're able to work together to take what works locally and then spread that up nationally. Next slide, please. So as a network, we've signed up to a shared vision, and that's to be committed to spreading healthcare innovation at scale and pace to improve health and drive down costs and stimulate economic growth. Next slide, please. And to enable us to do this, we've also agreed on some key AHSN priorities, which include supporting adoption and spread, but also transformation and the stimulation of economic growth. Next slide, please. So to give you a bit of an idea of some of the things that we do and some of our activities, as a network, we have a number of national programmes that specifically look at adoption and spread. And these include programmes of work around prescribing errors and transfer of care around medicines. And depending on the local need, the national programmes for 2018-20 that are shown on your screen now are still being adopted in some areas, and they have resulted in some fantastic impacts. And next slide, please. You'll see on this slide, we've also got 3 additional programmes that are scheduled. And while these have been delayed due to the COVID situation, we do anticipate that these will be starting in 2020. Next slide, please. So obviously we know that times have been challenged at the moment, and the last few months for the network, we've very much tried to adapt to the needs of the systems that we function within. So throughout the current COVID situation, we've very much responded to support the national effort, and many of our teams have been deployed to assist the rapid rollout of things such as digital technology. And we've seen some great successes around the online triage and video consultation. Next slide, please. In addition to our adoption spread activities, we've also had many of our staff redeployed back into the NHS, and we've supported our local organisations to deal with inquiries around things such as PPE. So we've very much been embedded in the system to really understand the changes and the needs and the requirements of things that have been going on, not just previously, but during and now looking to the NHS reset. Next slide, please. So going forward, there's a great opportunity around the NHS reset, and we continue to adapt and respond as we are required. And as a network, we've teamed up with the NHS Confederation and the Health Federation to explore how we can look to understand and translate the best COVID initiatives to everyday practice, but also to learn from some of the lessons over the last months and see how that can support us going forwards. Next slide, please. One of the key priorities for the AHSN network is around economic growth, as I've mentioned, and as part of this, we're commissioned by the Office of Life Sciences to provide an innovation exchange. So through the innovation exchange, we support the regional import and export of healthcare innovation, and this activity is achieved through 4 main functions. So the identification and communication of need from the healthcare system, so that's looking at the system-led challenges. Innovator support and signposting through a range of different activities and services, so that's getting your innovations to the right people. Evaluation in real world settings, and the spread and adoption of supported innovations. Next slide, please. So essentially, as AHSNs, we are innovation brokers. And while we don't always deliver all the support ourselves, we can help you to connect, find the right assistance for you with the right people that can help you to get to where you need to be. The support we provide is across the innovation pipeline, and the innovation pathway sets out a range of services we offer to support industry, and we tailor our needs within the region. So while not all AHSNs would offer something for every element on the innovation pathway, there are different AHSNs that we can work together so we can make sure that you get the right support for you. Next slide, please. So to enable a streamlined journey for innovators and to enable you to be able to access the support from the regional innovation exchanges, we've created the National Innovation Exchange. And this is a digital gateway to the regional innovation exchanges, and it can be accessed through the AHSN network website. The National Innovation Exchange enables you to not only search for your local innovation exchanges and understand where your local AHSN is, it also lets you see some of the regional challenges, some of the good practice case studies, but also access to contact details for the regional commercial teams. So this can help you identify people that can support you in your area or other areas to find the right people who need to see your innovations, but also help you to demystify the system and understand the challenges that are faced in the area that you're looking to work. It also contains a directory for innovators detailing funding opportunities, partner organisations, but also access to relevant news from the AHS network that's relevant to innovators and industry. Next slide, please. So in addition to our Innovation Exchange, we also have our Bridging the Gap event, and this brings together everything under one roof. So these events enable you to better understand and engage with other AHSNs, the wider innovation landscape, the NHS and healthcare market, but also you can start to meet people to understand how they can support you on your journey. These events happen at a national and a local level, and again, you can find out more about these on the AHSN network website. And there will be some of these starting to come up over the next few months, and they're likely to be virtual, but they're really beneficial to make some of those contacts in networks and understand what support is out there. Next slide, please. So our challenge is not a short-term challenge, but our collective impact to date has been significant, and we're continuing to make a difference for patients and for the public, but also for innovators and clinicians for the healthcare system. So in 2019-20, we saw over 400,000 patients benefiting from innovations that have been adopted and spread through the programmes that the AHSNs have supported. And from an economic growth point of view, we've had interactions with over 11,600 companies and supported over 4,000 since 2018. So we do support quite a lot of people in a lot of different ways through a lot of different areas of the healthcare system. And while we're still waiting for information on our economic growth metrics for this year, just to give you a bit of a flavour as to what happened last year, in 2018-19, we saw 188 jobs safeguarded, £152 million worth of inward investment leveraged, 691 jobs created, and we supported 2,605 companies, and that included 3,630 innovations. Next slide, please. So as a network, as been mentioned this morning already, we do support the SBRI Healthcare Programme, and we have an ongoing commitment to support this programme. The Urgent and Emergency Care Call is supported by the West Midlands AHSN and Health Innovation Manchester, and each competition is supported by 2 AHSNs to support that going forward. Prior to this launch, a lot of work has already gone into exploring the challenge from a clinical and a commissioner perspective. And what we've been able to do is utilise our existing networks around this area to be able to support the definition and be able to clearly define what's required for this call. So this enables the SBRI call to be demand-led and challenge-driven. So your innovations are really what the NHS needs at the moment, and it ensures you can actually respond directly to the needs of the NHS. But it also helps us to be able to feed the innovation pipeline and delivers that required pull or need from the healthcare system to enable the next step in the adoption and spread to actually happen. Next slide, please. So hopefully I've provided you with a bit of brief introduction to the AHSN network. Essentially, we are here to support you with your innovations to help you get them to the right people and to be able to identify the right support to be able to take those forwards. So on the call today, there's myself and there's also Richard from Health Innovation Manchester. So hopefully if you have got any questions, we'll be able to answer them.
Thank you very much, Tammy. I'm just conscious of the time, and if you have particular questions for the AHSN, if you could flag that in the Q&A, and I will field those to Tammy and or Richard as we go. But I think we'll in order to get through as many of the questions as possible, we'll just start the Q&A session now. What we're going to do is largely myself, Fanny, and Katerina from the PMO will kind of rotate around answering some questions as we go through, and hopefully we'll get through most of your questions that you've got there. Please continue to use the Q&A. If we don't get time this morning to answer them, you can feel free to do the drop-in session later on, and also just be assured that we will provide answers to all the questions on the website after this event with a copy of the webinar. So I'll kick off with one of the first questions, and it came up in earlier talking about the clinical, which is to do with social care projects. I think so. Social care projects which reduce demand on ED departments, are they in scope? And I think the answer to that is absolutely. So what we're looking for is the key challenges that were identified. Those are the key things to focus on. There's more detail in the briefing which gives some descriptions and some ideas, but the key thing is we're trying to stop people arriving at the front door, and to, if they do arrive at the front door, to manage the process more effectively as to what happens to them, the flow through the system. So that's very broadly the two kind of key areas. So social care is definitely in. So Fanny.
Yes, absolutely. So there was one about confusion perhaps between the shortlisting up to 25 applications, and then the slide I presented, showing the success rate with 188 applications. The success rate slide was about an overall number of applications that made it through. So just to clarify, within the one competition, at the shortlisting stage, we are hoping to take forward the 25 most promising applications to the panel meeting, the phase 1 panel meeting. So I hope that's a little bit clearer. But yes, we're hoping to take up to 25 applications to that point.
Katerina.
Hi, everyone. I will address a couple of questions about the length of the phase 2. There were a couple of questions about the projects being longer than 12 months, if this is possible. And the short answer is no. At the moment, we appreciate the challenges, and we will discuss with NHS England in the future, because we know that sometimes it's challenging to deliver something meaningful in 12 months. But for the moment, the contract is strictly 12 months for the project. Thank you.
Great. There was a question about does the call extend to easing ICU burdens? And I think so. I think the answer to that is not specifically. I think if you made an argument about ICU being or reducing the burden on ICU, which would help the flow through A&E, that might be possible. But I think in particular what we're more concerned about is the emergency department specifically in this case. Fanny, next question for you.
There was one around any limitation on working with European partners. So the call is open to anywhere in Europe. So you can, so there's no limitation specifically on European partner. However, I mentioned about it being an invitation to tender and a competitive process, and the choice of European partner, against other partners needs to be justified in the application. So that's the main thing to take on here: the competitive process and the justification of choice of partners.
Can I throw a question at Tammy? I think potentially, or at least for your insight, Tammy. There's a question about thoughts on the adoption of new innovation versus current state, and what are the particular challenges that people need to be thinking about in terms of I guess state of the art or current technologies versus something that's completely innovative.
Yeah, I mean, I think there's with regards to sort of new and existing, I think the challenges can often be quite similar, but I think one of the things that Chris has already mentioned is that the NHS doesn't necessarily always operate the same. So I think from a company point of view, it's taking the opportunity to actually understand that individual area, whether that's a hospital or whether that's social care within that specific area, and just be open to the fact that the challenges may be slightly different. So we may have something that's quite new that's adopted quite quickly. We may have something that's been around quite a while that takes a little bit longer. But I think taking that step back and taking the chance to actually understand those specific challenges at the outset, and being mindful that actually there might be a little bit of additional work that we need to do, and that is something the AHSN can help understand. I've seen a few questions come through the question answers around how do I meet Chris, how do I speak to people, how do I understand, how can we understand the challenge statement. That's part of what the AHSNs are here for. I mentioned in my presentation around the Innovation Exchange, we do have a common industry engagement form that we all use, and that can be accessed via the Innovation Exchange. And what I would suggest, if you do want to speak to people, you do want to actually get into the healthcare system and actually fully understand those challenges that are relevant to what you're trying to do, and you want to speak to some clinical people that are experiencing the challenges that you think they are. So you're not that sort of person that Chris mentioned, sitting in the office and thinking you know what it is. I would recommend going to our Innovation Exchange, completing the industry engagement form. In the first instance, wherever you're based, you can find the contact details for your specific AHSN, and that will go through to them, and they can then start to have a look at that and see who in their area is interested, where the pull is, who you need to. And from a West Midlands point of view, that's very much what we do within our Innovation Exchange. We take you as an innovator, we'll put you in touch with some of our expertise within our immediate team. We can link into our networks, we can identify where the pull is, who the people are, the right people, and we can help you demystify that, the system and the challenges associated to it. I think the only other thing I would probably say is don't underestimate the changes along the pathway. I think some people think that they can come in and their innovation is for a specific part of the pathway, but actually the implications that it has for the rest of the pathway, or if it's in primary care, the implications in secondary care, or vice versa, and the funding around that, it can be quite complex. So taking that time to actually really understand that and work with your AHSN and your local organisations can really, really help you on that adoption journey.
Great, thank you, Tammy. I'll just pick up one very quick question. It says, can two companies partner synergies for two solutions? We're a good fit. Absolutely. We'd encourage you to do that. I think you can see from the size of the challenge and the fact that, as was pointed out by Paul, referring to some previous work, this is not a new problem. It's been increasing and it's been happening for a long time. The NHS has been looking for solutions to this for some time. It's not necessarily going to be a simple solution that someone individual can provide. So two heads better than one, maybe three. Work with find appropriate partners to do that. And there was another question somewhere around phase one needing to partner with an NHS organisation. I think it's going to be difficult to do this project, or to do a project that relates to this and to solve this problem without some sort of partnership with an NHS organisation. If you don't have one lined up, one of the things you might want to think about is whether that's part of your phase one project, is to identify and to narrow down on the appropriate partnerships that you will need to deliver your phase two project. So just bear that in mind. Again, have a look at the invitation to tender documents and the guidance for the call to understand that. But that would be, again, making your application compelling is going to be useful, but we appreciate the timelines. If you haven't got partnerships in place, it's quite difficult to get everything signed and sealed at this stage. Fanny.
There was another question, perhaps following on to that, requirements for phase one, and whether you need to be a company to apply for phase one. And although the program is very well suited for SMEs and industry generally, you do not have to be a company. But I think what's really important is to be able to have a clear and demonstrable route to market. So sometimes, academic organizations need to think about this, whether that's in the form of a spin out or collaborators, but that's not an eligibility requirement for the program and for phase one.
So I will take the one about the previous SBRI call on emergency care. So there is an ask about if these innovations have been adopted by the NHS. Something I want to clarify is that the fact that you get SBRI funding doesn't necessarily mean that you will be adopted. We recognize that there is still a lot of work to do after your funding is awarded. However, I can name a couple of technologies, for example, CareFlow that had a lot of traction, or Current Health, previously called Snap 40, they did generate technologies that are now in use in the NHS.
Okay, there was going back to there was another question related to social care style innovations that would help discharge. And again, just to clarify, yes, social care innovations are absolutely where they can help with the process. I think what you need to do, you should have a look at the specifics of the challenge in the brief. We haven't got time to go into all of the details about what we're looking for and what we're not. There are some things in the brief which we're not looking for. So as there are some exclusions and things that we think don't need to be innovated, but absolutely social care options for easier discharge would potentially be part of a solution to this. Fanny, have you got another question?
Yeah, there was another question I saw, and I think it's to follow on from what you've just said. Whether preventive remote monitoring would be in scope to keep people out of A&E. So we're looking at reducing the burden. And again, it really depends what the technology is, but that could be within scope of the core. And again, there's a lot more information in a challenge brief that says exactly what we're looking for and what is not eligible for this competition. So for particular technologies, it's really worthwhile to look into the challenge brief.
Yeah, so you're hearing that quite a few times. So it's like the instruction you had at school when you're doing your exam. Make sure you read the question. Absolutely true. Just as a reminder, one very simple question here: can the tender be with an HEI and a higher education institution? Absolutely, and that may be again the people that you work with and that you involve in the collaboration with. Obviously, you use the people that you need or the organisations that you need to deliver what you're proposing to deliver. So what the panel will be looking for and the assessors will be looking for is a team that makes sense to deliver what it is that you're proposing. So absolutely, if you need university or it would add value to your proposition, by all means, they're certainly eligible to be part of that. Fanny, and if you've got another one.
Well, there's one around regulatory approval. So should the innovation have regulatory approval or have already a CE marking already in place? The answer is no, it doesn't have to be. It can be, relatively early stage to enter into phase 1. And CE marking can be a part of the project proposal or even the phase 2 proposal, absolutely, to demonstrate that there's a clear route to market. So no, it's not an eligibility criteria.
Okay, and there's another eligibility quickly before I'll leap in on while we're on eligibility. Are you still eligible to receive if you had previous SBRI funding? Absolutely, and there's presumably this is a different innovation, so there's no reason why you can't. And we have a number of companies that have been funded more than once through SBRI. Are community interest companies eligible? Yes, in principle, as long as they're a registered organisation, then that's absolutely fine. Fanny, I don't know if you've got another question, or Katerina, maybe you're ready with one. Meanwhile, I'll pop in here. Someone missed the webinar, most of the webinar. The webinar, just to remind you, the webinar it has been recorded, and there will be the questions that are being answered will also be there'll be a version of that put up on the website after once we have a chance to do a quick edit and put that up there. So that will be available to look at afterwards. So you don't need to miss anything. I'm just conscious of the time. Is there another couple of quick questions from Fanny
I just had one about, there's a question around application that focus on either the reducing number or improving flow, and whether there's solutions that cover both area, and whether they need to choose one or the other or focus on one. That's absolutely fine to have something that covers both. And it's just, I think, when you go through the application process, just choose the subcategory on the online system that fits the best technology. But we're really looking at solutions that address this challenge, this NHS challenge. So that's absolutely fine.
And can I just add a quick question? Many people are asking about the recording. The recordings will be available, I said next week, because we need to edit them. We will see if we can make presentations available sooner than that. However, any questions you have will be answered if you read the briefing document, the invitation to tender, and the application forms are online. So really, whatever you need to know for application is there. And obviously, you can use our email address to contact us if you have any specific questions you want to address, unless you want to use one of the one-to-one sessions that are available soon. I put the link on the chat for everyone who wants to have a one-to-one with the PMO just after this webinar.
Right. So I thank you, Katerina. And I think at this point we need to wrap up, because we've got to allow Alice a chance to set things up for the one-to-one session. So if you have got unanswered questions, or you have specific questions you would like answered by the PMO, the link is up there on there, and you should, if you were registered for this, you will have had an email to your registration address, and which will have the link in it, so you can join a Zoom, at least the waiting room, and there'll be a number of us available for some sort of 5 minutes or so for one-to-one sessions. So it's kind of like a drop-in in virtual space, and I think at that point, thank you very much for your attendance, and hope it was useful.